How many people typically watch or log on? Do you have any idea?
Usually by end of the day, because it's archived on YouTube as well, it's around 500 which actually watch by end of the day.
We are
live usually are between 250 and 300.
We are live, sir.
Friends, good evening. Welcome to Indian Arthroscopy. Yeah, it's already. Welcome to Indian Arthroscopy Society webinar today. It's webinar number 94th today. And we are going to talk about patellofemoral instability. Where are we today? We are lucky that we have a very senior expert on this topic, Dr. David R Diduch, and he's a division head from sports medicine from University of Virginia, US. He has got extensive work in patellofemoral instability, patellofemoral arthritis, and he's one of the masters who can let us know what is latest happening in PF joint instability. Dr. Shreyash Gajjar will kindly introduce our guest speaker today, followed by a talk by him, and then question answer session, including the questions which come in the chat box today. Dr. Shreyash, please.
Hello, everyone, and welcome to this Master Series webinar on patellofemoral instability. Where are we today? Patellar instability is a common problem seen by both the orthopedic surgeon and physiotherapist, which is common both in the skeletally immature and the mature group of patients. And instability is a multifactorial problem. However, importantly, there is a large variation in the surgical treatment that occurs globally. And today, in order to get his thoughts and experience on this topic, including certain controversial aspects of evaluation and management, we have Professor David Diduch from University of Virginia, USA. He specializes in sports medicine, knee and shoulder surgery with a particular interest in patellar instability. He is the Voshell Professor of Sports Medicine in the Department of Orthopaedic Surgery at the University of Virginia, where he has been in practice for the past 25 years. He's also the Division Head of Sports Medicine, Head Orthopedic Team Physician for UVA, and the previous Executive Vice Chairman at Sports Fellowship Director. After college at the University of North Carolina, he completed medical school at Harvard Medical School, orthopedic residency, and a master's degree at the University of Virginia, and subsequently a fellowship in sports medicine and reconstructive knee surgery at the prestigious Insull Scott Kelly Institute in New York. He's been active in several committees and leadership for the AOSSM, is a member of the Herodicus Society, the International Patellofemoral Study Group, and prior president of the Virginia Orthopedic Society. He remains very active in research and academically pursues over 140 publications with over 50 book chapters and 30 research grants. So really, he is the right speaker for this Master Series talk on patellofemoral instability. Where are we today? And I would now kindly request him to please share his screen and share his views on this topic. Thank you, Dr. Diduch.
Thank you very much. And I appreciate that kind introduction and the opportunity to speak. Good evening to everybody. I look forward to some questions here at the end. Everything okay with the audio and video?
Yes, thank you.
Perfect. Perfect. Good. So this I think is an excellent topic. It's a topic that's evolving. I think it's an area that we're all learning, and I hope that we can learn from each other today. So just a few slides first. These are my disclosures. And this is where I live in Charlottesville. It's in the middle Atlantic on the east coast of the United States. It's about 2 hours south of Washington, D.C. That upper left slide is my neighborhood. I drive past this area on the way out each morning, and there are often hot air balloons that go off from this little field. We're entering fall. In the bottom left, we have beautiful trees that turn color in this area. We're at the foothills of the mountains, and it's a small town, a small college town, but with a big medical center that you see here that continues to expand with a level 1 trauma center and a big college. And I take care of the teams here and do sports medicine. It's been a wonderful place to work and raise a family. Very historic campus. If you ever come, it's worth a visit. It's a beautiful campus. It was designed by one of our early presidents, Thomas Jefferson. He was actually the architect for this campus. And you can take tours of this building, which is a rotunda, which was the original library, and it's a very nice place to live and work. And the medical center is immediately adjacent to this campus, so it's all right there together in a very pleasant place. We have a large referral area, even though we're a small town. We serve an area that's quite large population-wise, but have the benefits of living in a small town. So let's talk about patella instability. So just a few very basic things to kind of set the stage. With a patella dislocation, the MPFL tears every time. I think I really don't look to the MRI to decide did the MPFL tear or not. If the patella dislocated, we know the MPFL is incompetent. It's either stretched, torn, attenuated, whatever you want to call it. It's no longer a functional MPFL. And then we have to say, well, a knee with normal anatomy doesn't dislocate the patella. There's always something else going on that causes this patella to spontaneously dislocate. So then the next question is, why are some knees then so unstable and others not so? And what should be our threshold to consider correcting the anatomy and the anatomic risk factors? And that's really the question. The MPFL here, we understand, is key for patella stability. It's 60% of that restraining force. It's immediately distal to the VMO. And we've learned that if we do a simple imbrication or repair or advancement, that it tends to stretch out. You may improve things temporarily, but it tends to stretch out with time because the MPFL is not anchored to the femur or the patella. It's torn at some place. It's rare that it's just stretched and anchored still. So this doesn't work, and I think we all understand the importance of moving towards a reconstruction. So just to reinforce this clinical trial, 80 patients randomized to non-op or repair. There was no difference in the outcome. So clearly, if you follow your patients long enough, you realize that repair or advancement is not going to be the answer. And if you do have up to 46% redislocation rate after simple repair. However, reconstruction works extremely well with very low redislocation rates and excellent meta-analysis. I mean, very low recurrent instability numbers. So the real key is to identify those patients that need additional bony procedures in addition to an MPFL reconstruction. Use a graft. Reconstruct the MPFL. Don't rely on some type of a repair. The graft is going to be strong, reliable, and predictable. A Gracilis graft is stronger than the native MPFL. The Gracilis is my go-to graft. You can use the semitendinosus. I think allograft or autograft is optional. They both clearly work well. This is extra articular, so they're both fine. I tend to use an autograft, and Gracilis is fine. I mean, unless there's a problem with the Gracilis harvest, I will go with the Gracilis 95% of the time, and that's sufficient. The real key is where you put it. So on the patella, it's not nearly as important, and how you attach it is also not nearly as important, but it's basically the proximal half of the patella. Whether you use a single or a double loop is also not as important. I tend to prefer a double loop to the patella because it covers more of the footprint, and I think reconstructs the anatomy better, but there's really been no studies that shown superiority for one versus the other or fixation method. So two basic ways that these are fixed to the patella. One would be with suture anchors. The advantage is this can be smaller holes in the patella, and you can secure it to the side, but you're then relying on healing. Bear in mind, if you're using absorbable suture anchors, but non-absorbable sutures, we're not sure what happens in 6, 7, 8 years. We really don't have many studies that have looked at that once the suture anchors have dissolved, and whether you get reliable healing against the side of the patella. Disadvantage to two suture anchors is the cost. They're going to be $300 or $400 or equivalent, and you may have pullout. These anchors are not designed to go into patella bone. They're designed for glenoid typically, and I think we've all had the experience that you place an anchor, you go to test it, it pops right out of the patella, so that's a little disconcerting. Another option can be very short oblique tunnels that you see here in the bottom left x-ray with the arrows. So starting on the side of the patella, and then you see on the right side here, I'm drilling with a 3.2 millimeter drill bit. So basically the drill bit for a large frag screw, just 3-2 drill bit, dropping as low as I can to stay in bone and aiming through the anterior cortex. And there you see a beath pin next to it to help me align my second drill hole, and then loop the graft through the tunnel and back down. Then there's no need for a suture anchor. The fixation is tremendously secure, and you avoid the implant cost of 2 anchors. And this is very, very reliable fixation. And this is my go-to unless it's a very small patella, or if I have to use a semitendinosus graft. A semi-T is not going to fit through this, but a gracilis fits very nicely. And if it's a little snug, some sterile mineral oil will help it through. So what about fracture risk? I think this is something we're all aware of because of some publications. Bear in mind, those publications were with a different type of tunnel, with a larger 4.5 millimeter diameter tunnel and fully transverse. That's not a good idea. So we looked up our experience here over 6 years, and it's even grown beyond this now. This is submitted in process for publication. And we had 1 fracture with somebody who fell directly on their patella a couple of weeks post-op. No fractures with the suture anchor group, but interestingly, the odds ratio for further instability was 3.3-fold higher with the suture anchors. And I think that's because there may be issues with pull out or loosening on some occasions with these, and maybe even the reliability of healing of the graft to the side of the patella. So just another way to do it that may be something to consider. But again, this is not the same as what we started with 10 years ago with these large transverse tunnels. That is not what I'm advocating at all, and not ones that go all the way across the patella. That is definitely a concern for fracture risk. So the key really for doing an MTFL well is the femoral location, and we've got to be precise here. I use fluoro, I use X-ray every time, and I pick Schottle's point, as you see here in the bottom left. And it's remarkably reliable, but I then check that with the graft looped around the beath pin before I commit to drilling the tunnel, and watch the excursion and make sure that I've picked the right spot. You see the anatomy there on the right, and that's going to go between the epicondyle and the adductor tubercle. But I don't rely on palpation alone. I'm going to check an X-ray. I use big C-arm rather than mini C-arm to really see it well. And we've done some research here, and what do you do if you get it wrong? What are the consequences, and how do you troubleshoot intraoperatively? So this is looking at knee range of motion and graft displacement, and the key line is this green line at the top, and that's if the graft is placed too proximal. And as you flex the knee into at greater degrees of flexion, the graft is getting tighter and tighter. So that's the worst mistake. And so we came up with this phrase. And I think this is very helpful for people to keep in mind as they troubleshoot in the OR, and as your knee flexes, what does the graft do? If it gets tighter, then you're too proximal. So high and tight is the thing to remember. As you're flexing the knee, the graft gets tighter, then I'm too high, I'm too proximal. That's the worst mistake. So either they're going to lose flexion, or they're going to rupture the graft, or there's going to be so much pressure, you're going to have articular cartilage damage and chondrosis. If it's the opposite and it gets looser the more you flex it, and the normal MTFL should get slightly loose as you flex it, because it's really most active in that first 30 degrees of flexion, closer to extension. But if it gets too loose, then you're probably too distal. It's hard to get too distal because you run into the notch. But high and tight is the thing to remember, and that is the worst mistake to make. And you need to adjust it and get it right in the OR. And then when we tension the graft, tension is probably too strong of a word. I think set the tension in the graft with the knee just flexed enough for the patella to be fully engaged in the trochlea, so that you avoid the tendency of pulling too much and over medializing the graft. That's the easiest mistake for me to make, and I think for any surgeon to make. We think of tensioning any graft like we think of an ACL, where we pull hard and then we set the hardware, but this is really very light tension. Basically, just take the slack out of the system and then fix it at that point. I use an interference screw on the femur. I think that's probably what's most commonly done. And bear in mind, as you insert those screws, the last few turns tend to wrap the graft and pull it a bit more into the socket. So you have to then back it up a half turn to release that additional tension on the graft, but avoid over tensioning, because that can definitely lead to problems. So let's move on to the bony issues here. And for every patient that I see as I'm doing decision making for procedures, I'm going to run through the most important anatomic risk factors and decide do any of these need to be changed and which one is the most important. And I think all of us who do patellofemoral surgery know that many patients have multiple anatomic risk factors, and I think therein lies the challenge, which and how many and if to correct. So I'm going to think about malalignment, genu valgum, alta, and dysplasia. And the general principle is you can't pull the patella over the bone. You got to put the bone under the patella. And if we're thinking that we're going to reconstruct the MPFL and pull it enough to center it, then that's going to come at a cost, because we're going to create a vector that doesn't only go medial, but also goes downward and is going to increase contact pressures and cartilage damage and pain potentially. So let's first talk about malalignment. The TTTG is really the most quantifiable and reliable way now for us to assess coronal malalignment. I think we're all familiar with measuring this, and the number of 20 millimeters as being the threshold for abnormal. Important to understand this is a vector concept, and so it's not measuring to the highest point on the tubercle, it's measuring to the center, thinking about the way the tendon attaches and drapes over this tubercle and the way it's aligned. So these black lines are oriented kind of to reflect the vector of the tendon draped over that prominence. And so I'm going to measure to that point right there, the black line, or where the white line is perpendicular. And that's, otherwise you'll tend to underestimate what the TTTG is. My goal is going to be 10 millimeters after any correction. So the 20 millimeter number is useful, but it's not a hard and fast number. So you have to interpret that with other things. So I'm going to look for evidence on clinical exam for lateral tracking and tilt to the patella. And especially if this is combined with patella alta, I may have more of a threshold to correct the tubercle by moving it medial and potentially distal. So it's not an absolute number, but it's a very helpful number and certainly an important one to take into account. Another very useful number that I'm using more and more, this was a paper, if you haven't read it, it's worth a read, in the American Journal of Sports Medicine by Mistovich in 2018. And it introduced the concept of the PTLTR, which is patella tendon lateral trochlear ridge. This also, I think, is quite a visual way to understand the vectors that are going on. So you look at this axial view of the trochlea, which is relatively flat, and you see this patella tendon draped over the side. So the vector is really working against this patient to pull the patella laterally. And if you're going to try to just pull that patella back with a graft and putting more tension on it, you're really trying to counteract this vector that's pulling the other way, and the net effect is going to be a posterior force. So this line is also perpendicular to the posterior condyles, and you take it to the apex of the lateral trochlear ridge, which is the circle there that's 2, that right at that apex, and then you measure how much patella tendon is draped over the side, and this is the cut, that's the first cut distal to the patella, that's all tendon. And you measure that, which is the number 4, you measure that in the direction that the tendon is lying. So you don't go directly horizontal, you measure it in that oblique direction where the tendon is. And they found that anything greater than 5.5 millimeter was abnormal, and they actually found this was more predictive of recurrent instability than the TTTG. With very good sensitivity and specificity. So I measure this as well and take into account. And I think, it just kind of makes visual sense when you look at it in terms of the vector that's going on there. So here's a good example. This was a patient with a PTLTR of 12.5 millimeters, so clearly high. And that visually you can see the vector is not favorable, but their TTTG was only 13, interestingly. And so this was a patient, when I got in there, this is the arthroscopic view, and you really see evidence of lateral tracking and chondrosis. And this was a teenager, and it's clearly with instability. But I think this shows how maybe this may be a good number to take into account, and maybe high even when the TTTG is not. So valgus, I think people are comfortable measuring this. You have the mechanical axis of the lower extremity, then the mechanical axis of the femur. And if you have greater than 6 degrees of excessive valgus, that meets the threshold for being abnormal, and you may consider a distal femoral osteotomy. You can also look at the lateral distal femoral angle to confirm that the deformity is in the femur. And you may need to consider an opening wedge osteotomy fixed here. And understand that if you do a DFO, you will also improve your coronal malalignment in regards to the tubercle. Your TTTG will improve by 7 to 10 millimeters, basically, as you're correcting it to normal. So that's helpful as well. If people are still growing, you can use guided growth with a fascial tether if they've got more than a year left. Very, very useful operation. So the patella alta historically was measured with the insult-Salvati ratio, which included the full length of the patella, but that also included the patella nose. The patella nose has nothing to do with congruity or articulation, and so really is not a helpful, the insult-Salvati ratio is not so helpful anymore in terms of understanding true alta and how alta impacts stability for this patella. And it's been replaced by the Catan Deschamps index, which uses the articular length of the patella, and instead of measuring the full length of this tendon, it measures the distance down to the tibial plateau. The same ratio numbers apply. 1.2 is considered abnormal and 1 is normal. You can see you typically measure it on an MRI, but you can on X-ray. You see that on the left. And another measure that's very useful is the patella trochlear index. So that's basically on the sagittal view, the amount of overlap of the articular cartilage of the trochlea relative to the articular cartilage, the patella length. So there may be times where your CD ratio is not abnormal, but the patellotrochlear index may be. If you have a short trochlea, then it's the same as a high-riding patella in terms of lack of engagement. And this definitely occurs, especially in dysplasia. You may have a very short trochlea with a big bump, as you see here, and that then can have even more pronounced effect on the patella. So I measure both of these. And here's the effect of alta. This is with an knee in full extension, and you can see there's the patella, and there's no groove whatsoever. It's up on the shaft of the femur. You see no cartilage on the femur cut, and so that patella is going to tend to be very unstable. And if there's any additional malalignment, then it's going to have a pronounced effect on the patella tracking. So the J sign is extremely important physical exam finding, and this you see on the left is what we call a jumping J sign. So not subtle whatsoever, really jumps hard in and out of the groove as the knee is ranged. So what does that mean? It means that the patella fully leaves the restraint of any groove whatsoever in extension. So that's either patella alta, which is significant, or trochlear dysplasia, or both. And I hope the takeaway today for many people is if you have the combination of patella alta and dysplasia, that is especially important. That is going to have a profound effect on tracking. And those are the patients that have a soft tissue procedure alone that are much more likely to fail. So my threshold is to correct patella alta, even though 1.2 is abnormal. There is some morbidity. It tends to go very well, but there is some morbidity to moving the tubercle, and we can often still adjust with a soft tissue procedure alone up to about 1.4. But if I've got a CD ratio greater than 1.4, I am going to distalize that tubercle just nearly every time. Also, with a patellotrochlear index less than 20%, I'm going to think hard about distalization. And if I have a JSON on exam. So these are my indications. And if I have that combination with some dysplasia, I'm really going to think about moving the patella distally, because that's going to really decrease the influence of the bump or the spur. So if I've got a large correction like this, that's over a centimeter, then I'll do a step cut and take the wedge of bone out from distally, slide the tubercle down and dock it, and transfer that wedge of bone up here into the gap and with the bone tamp and put it in place. I've gone more and more to using 3 screws, just as an aside. I use 3 screws almost always, and the middle screw I put off axis at a slightly different angle, because occasionally you'll get a split in this bone with any tubercle osteotomy, and that split can continue on up like a block of wood, but if you put the one off axis, then you avoid that problem. And it also enhances healing, because this can take a long time to heal. Be careful not to go too deep with your saw blade, because that becomes an increased fracture risk. If I've got a smaller correction, like up to 7 or 8 millimeters, I typically do a tapered cut like this and feather it and overlap it and slide it down. You can then remove this little piece of bone if you'd like, but you can see how that's been distalized as well. So let's move on to trochlear dysplasia. This is an area that I think is very interesting and probably controversial, but where there are a lot of opportunities to learn. I got into doing trochlear dysplasia surgery from what I learned from David Diduch in Lyon, France, and have followed his lead. And have learned a lot in the process. I've been doing this surgery for just about 9 years now, and just had a publication that came out this month in the Arthroscopy Journal with our experience. So I think the key, first of all, is to recognize it. And I go to the lateral X-ray. That is, I think, the important part to understand. So if we trace these lines, here's the notch. I hope you can see my mouse. And that's the notch with the cruciates, and as you exit the notch, that's going to be the lowest point of the trochlear groove, which is the blue dashed line. The red line is going to be the apex of the femoral condyles. Typically, the taller is going to be lateral. Where the two cross, they're at the same height if you're looking at it from the lateral side. So at that point, they're essentially flat. So the yellow arrow is flat. So if they cross there before you get to the top of the trochlear, that's what's called a crossing sign. And that means it's flat at that point. Now, if you continue further proximal and it goes further anterior, which is the green dots, then that's going to be a supratrochlear spur, which is going to be a prominence or a convex trochlea the further proximal you go. So the apex of, or excuse me, the deepest part of the trochlear groove, this blue dashed line, in a normal trochlea would come up proximally and be flush with the anterior cortex of the femur. But if it continues out anteriorly, that is sitting proud and it's going to be a bump. Now, bear in mind, you've got cartilage on top of this. So once you see this anatomy and this spur, you know you need some three-dimensional imaging to really understand its significance and shape. This is the same knee. This is the same knee. On the left is a standard sunrise view, merchant view, 45 degrees of flexion. We all agree that looks unremarkable. That trochlea, the congruity looks unremarkable. The knee on the image on the right is a CT arthrogram in full extension. And there you see the patella sitting on top of this convex supratrochlear spur. And you understand the problem. And you can also see the chondrosis that's starting from this, and understand how this can lead to patellofemoral arthritis later. And you see, this is the same knee. So you know you need three-dimensional imaging when you see that spur, like you see here, then this may be what's going on, and you understand that, well, I need to do something about this perhaps. Now, what we do about it is the next question. People often ask me, well, if you change the shape of the trochlea, what about the patella articulation? I mean, is that no longer congruent because you made it different? Well, I think you'll see as we move forward, all I'm going to do is take the shape that's distal in the trochlea and bring it proximal and just continue it so that the shape proximally mirrors this. And I would argue that this is the opposite of congruency. If this is the existing state on the right, that is anything but congruent. So I'm actually going to be improving the congruency issue. So I've never had any concern or problem with the way the patella articulates with the new trochlea after trochleoplasty. But take away that it's not about flatness. I have people referred all the time because they get the sunrise view and it looks relatively flat and they say, oh, this person needs a trochleoplasty. No, that's not the issue. I'm looking at the lateral view for the size of the spur, and then I'm looking at whether they have a convex trochlea, and you can get some bizarre shapes to these. Here you can see this big bump that says anterior to the femur, and there's the three-dimensional imaging too with a CT scan. And there's no way you're going to solve this problem with a soft tissue procedure. So as you see this little cartoon animation on the bottom left, we're going to take this prominence, create a cavity behind it, and drop it down flush to the front of the femoral shaft and try to increase some depth with it. But it's not so much about making a groove deeper as much as it is removing this convex bump. So I'm going to quantify the spur on the sagittal cut at the notch. Remember, there should be nothing sitting in front of the anterior femoral cortex. This is all prominence or convexity, and you can measure the height of this because it's going to include cartilage plus bone. And with the convex trochlea, it's really like an egg on a table, which was Philip Schottle's expression. I think it's a very good one. And if you examine these people asleep, you realize it just can go either direction, and it's a highly unstable condition. So the MRI criteria for trochlear dysplasia are not that useful for decision making. This is more just whether it qualifies for that diagnosis, and it's a spur height greater than 5 millimeters, cartilage plus bone. sulcus angle that's flatter than 145. And then you can look at the patella depth, the mean height of the median lateral side minus the depth here. For these that are convex, it's obviously going to be an inverse number or a negative number. They typically also have a very short hypoplastic medial trochlear facet. But the real question is going to be, what do you do about it and what should be our threshold? So the Gajjar classification was descriptive, and the A's are basically flat and the C's are really deficient on the medial side, but they don't have a bump. They don't have a supratrochlear convex spur. They just have this unusual shape to the anatomy. We can't really do much with those, and we don't really have to do anything with those. The issue is with the type B's and the type D's. The B's are, the B's are basically flat with a bump, and the D has this cliff sign. But the mere classification into these two groups doesn't mean we have to do something. Here's the real question I ask myself is, does the spur influence the patella? So this is an arthroscopic view of a person with a J sign. You see the chondrosis, you see the big spur. I'm viewing from above, from proximal. Now I've externally rotated the foot just a little bit and watch what's happening here. This is a 19-year-old female, and watch the way it jumps. So that's what's, and this is with no tension on her extensor mechanism. So you get the idea, and you see how proud that bump sits relative to the shaft of the femur. I'm viewing from up in the superior lateral portal. And that's what we're going to want to drop down flat to the femoral shaft. And this, as you see, is a convex proximal trochlea. So, and then I also ask myself, well, can I work around the dysplasia? They may have this anatomy, but there may be an opportunity to work around it. I think this is a very helpful concept to understand. Even if you're not doing trochleoplasty surgery, you can maybe address this problem in other ways. So this patient has a patella alta with a patellotrochlear index that's almost 0. So any spur at all is significant because that patella has to navigate up and over or around that bump every time. And even a smaller bump is going to have a more pronounced impact if the patella sits high. So you may be able to distalize the tubercle, and then you bring the patella down closer to where the person has a bit of a groove, and you're across the bump, and it has less influence. So in this person had a pronounced bump, as you can see, but had tremendous patella alta with a CD ratio that was 1.5, a 0 patellotrochlear index, very malaligned with the TTG 26, a big jumping J sign. You see the vector in that bottom right picture is terrible for where that tendon is tracking. And I moved this patient way down and way over and solved the problem and left the bump there, didn't change it, and the patella is more engaged in the native groove. And this was a great solution to this, despite having some significant dysplasia. Moved him down 12, which is a lot, and over 13, and then did an MPFL reconstruction. So that's another way to think about it. And so if I have alta, I may be able to solve the problem that way. Again, flatness is not the indication. Flat on flat absolutely can be stable. So that is not my concern. And often with a soft tissue procedure alone, flat on flat can be stable, especially if I've got good patellotrochlear overlap for engagement, as opposed to a lot of patella alta. Again, we're getting back to these combination of risk factors being the issue. So there's two different techniques for doing trochleoplasty that are most widely done. There's the thick shell method, which I do, which I learned from David Diduch, and then there's the thin flat method that Philip Schottel is doing, mostly the Biraris method. The differences are the thick shell method leaves a 3 to 5 millimeter, really 5 millimeter shell that's both cartilage and bone. And so you think of it more as an osteotomy of that shell. We're going to purposely crack it with a 20 blade and a bone tamp, and then fix the then recontour it and fix it in place with number 2 sutures draped over these shingles and knotless suture anchors. The thin flap is going to make this whole shell very, very thin, malleable, and you're going to peel it back and shape the bone beneath and then fix it in the new position. So this is a case as we're just getting started. You see a very large supratrochlear spur sitting in front of the femoral cortex. Remember, the base of the trochlear groove should come up and be flush with the femoral cortex. This is like 11 or 12 millimeters up. That's a big bump, sitting way proud, dysplastic anatomy. I'm going to start with the osteotomes and take a wedge of bone out here. I'm going to start slightly on the articular cartilage and come down. I'm going to come way back here on the shaft so that when I'm done, it's going to be flush with the femoral shaft. Take that wedge of bone out and take that all the way around the proximal edge of the trochlea. I'm going to save that bone and mince it up, as you see here with my rongeur. And then I'm going to kind of draw out what I want to correct. So the blue line is the anterior femoral cortex. And that's where I want this to be sitting flush when I'm done. And if you extrapolate down distally to where it intersects the cartilage, that's going to be the distal aspect of my correction. And then I'm going to use the apex of the lines on the medial and lateral side where the curve transitions from going up to going down, which is that yellow arrow on top. And I'm going to start from there and then intersect my distal point, and then the same thing on the medial side. And you see that on the right-hand picture too. Now, most of these dysplastic trochlea have an abnormally medial trochlear groove. The dysplastic groove tends to be oriented very medial as part of the process. You can lateralize the new groove that you create and therefore improve your TTTG, and often by up to 5 or 6 millimeters. So my dotted line there, my solid line is going to be my new groove, which is more lateral than the native groove, which tends to be more medial, the dysplastic groove. So if my new groove is lateral, that's actually more in line with the tibial tubercle, and the TTG number goes down. So then I'm going to create a cavity behind this osteochondral shell. I start with a high-speed burr just to get it going, and then I convert to this offset guide. This is commercially available. I have no commercial relationship with this company, but I do think this makes the procedure safer. It comes in 2 different offset thicknesses, 5 millimeters, which is the one I use only, and also a thin millimeter. So you use it like a windshield wiper around that pivot point, and you thin out this shell down to the depths of your correction. And the nice thing is, you know how far that drill bit is extended with this guide, so you don't go too distal. And the other method, as I mentioned, the thin flap technique that Shuttle does, is to then switches over to the 3 millimeter offset and makes it thinner and thinner and thinner. And then they peel it up, lift it up like the hood of the car, and then reshape the bone underneath it. I have concerns about thermal necrosis with that, but I also have no experience with that. So I can't really comment on which method is better, but that is my concern. And I'm always worried about perforating the cartilage. So I much prefer the thicker shell. Once I've done that, I've got this cavity here in the back. It bounces like a diving board. I use a 20 blade and a bone tamp to cut this central crease to make my new trochlear groove. And the medial side is always flexible enough you don't have to cut it. You'll then have to go to the lateral side and just cut the corner. Bear in mind, do not cut all the way down to the center to intersect your other line, or then you got a free piece of bone. You don't want that. You just have to cut this edge. And then you can mold it and reshape it and press it down and into a new shape. Now I'm going to want to do something, because this transition where the cavity stops is abrupt, and it could potentially settle. And I've seen that on x-ray. It would just kind of drop down and settle. The patients do okay, but it's not an ideal looking x-ray. So I will take bone and I'll pack it in here, that little minced bone, to help with this transition. I'll also kind of pack it in deeper with any little cavities to kind of take up space, as you see me doing there with the freer elevator, my little cup of minced up bone and the slurry, and just kind of fill the cavity. And you can mash it down and mold it with your thumb, as you see here, and you have your correction. And then I'm going to place the suture anchors distal to where that cut is. This is a knotless suture anchor. It doesn't matter which one you use, come distal. And number 2 vicryl, 2 of them in case one breaks, and then drape a pair of sutures each over each corner to an additional suture anchor up here at the top. And then that you pull it down tight, and that's going to hold your correction. I've never had one lose correction. This is bone that really wants to heal. It's cancellous bone against cancellous bone. It heals very quickly. I'll take these free suture strands and I'll use a free needle to pass it through the synovium and tie it down here around the edge with a free needle and help cover up that area. And then that's done. So this is a before and after. You see with the osteotome, this is like an 11 millimeter spur, and now I've dropped it down flush with the anterior femoral cortex. by packing the bone and pressing down in the middle, you get a bit of depth. And depth is nice, but that's not the primary goal. The primary goal is dropping this down flat to the femoral cortex, so it's not a convex spur any longer. That's the primary goal. And as you see on the right, that black line, the anterior femoral cortex, matches up with the base of the trochlear groove. That's what I'm shooting for post-op, and that spur is gone. And this is a sunrise view, which looks terrific. So you want to show that one off. But again, the depth is the secondary goal. The primary goal is getting rid of that convex spur. So what about the articular cartilage? It tolerates those vicryl sutures very well, no problem. Here's 3 different patients. You can kind of make out where the crease was with the 20 blade before. That's where an anchor was. But they dissolve probably in the first 6 weeks, and it just doesn't seem to be an issue. So here's a short video. This is that patient I showed you earlier with a big jumping J sign. This is a sleep, right? And this is just a very pronounced J sign, a petite 19-year-old, very fit female, very large spur, sitting up there proximally, marked out my planned correction. I'm going to start with an osteotome. And I'm going to remove this wedge of bone all the way around the edge. Again, save that bone, mince it up. You'll use it later. Come in with a burr to start. The drill is not aggressive enough. It's hard to get started with that drill. So I'll start with this. And this is the way I used to have to do it until the guide came along completely. But now I'll just get the first half started and then convert to this offset guide, which again is very, very, I think, adds a measure of safety. But it's not aggressive. So you have to do this pivoting motion like a windshield wiper to get it to work. Now it's bouncing like a diving board. That's where you want it to be. And then I'm going to cut it with a 20 blade, increase it. You can put a osteotome behind that if you want to kind of support it as you're using the mallet. And now I'm going to pack a little bit of bone underneath the edges and even smaller pieces into the center and place my knotless suture anchors. Go well deep below the articular surface and put this distal to your cavity so that you have good purchase, and then pull them up over the top. The bigger the correction, the more you drop it down, the more you'll have a little bit of splay or separation up at the top. So that's what I'm looking for there. And you see a little bit of splay at the top. That's fine. That is no consequence. The patella meets that in full extension, and this will heal pretty well. So rehab, I do these all as outpatients, even in combination with a tubercle osteotomy. They all get an MPFL as well. Immediate physical therapy, the most important thing, and I really spend time talking to patients and their families, because these are often teenagers, and this is a big operation for them, is they've got to move it right away. Immediate motion is important those first few days to avoid stiffness. When I started out on this, I was tentative. I didn't, have any experience, and there wasn't much to reference, and I was more hesitant to move these people, and a lot of them got stiff, and the scar tissue can be very dense. But I've learned and solved that problem by having them move right away. When my first experience, I had 20% manipulation rate in my first, 30 or so. And by going to immediate motion, I've had 1 in the past 6 or 7 years. So that's the key. I use a brace basically in case they fall, but they can move fully, and encourage them to move very quickly. 50% weight bearing for 6 weeks, and progressing as tolerated after the first 3 months, and return to sport is about 5 or 6 months for these people. This is the paper that just came out this month in arthroscopy. So it gives us our 2-year minimum experience. So half of these patients had failed prior surgery. So it was a tough patient population. And with the trochlear dysplasia plus MPFL, we had no recurrent dislocation. So this is clearly an effective operation for those patients who need it. We also had no radiographic progression of arthritis, very important, no fixation failure, very high patient satisfaction and return to sport. But again, postoperative stiffness can be an issue if they don't move right away. So my decision making, all these patients get an MPFL. They get that as well, but I'm going to do a trochleoplasty, or consider it if it's a type B or D with a convex trochlea, not flat, convex, and a spur height that's significant, which for me now is 7 millimeters or more, and almost always these have a J sign on exam. And if they have patella alta, I'm especially concerned that they're going to need to have a bony procedure. And I'm either going to move the patella distally to correct the alta and get around the trochlea dysplasia, or I'm going to be doing a trochleoplasty. And especially consider this for revision procedures. Here's a paper, as well as others, we've seen that if you don't correct the dysplasia, they're the ones that do worse with revision procedures. So have a definitely heightened suspicion for that. So thank you for this time. This is our basketball team when we played 2 years ago in the tournament, and we won the national championship, and I got to go along with them for that, which was a real treat and a highlight of my career, certainly. But I hope we have some chance for a few questions now.
Great. Thank you very much for that concise, yes, very precise, content of this extensive topic. IPS, do we have any questions before
Yeah, but I think, Shreyash, if you can initiate discussions, and okay. Ranjit has questions, so maybe Ranjit can start.
Yeah, sure.
Yeah, Dr. David, it was an excellent presentation.
Thank you.
When you consider MPFL reconstruction for hyperlax individuals, MPFL reconstruction alone or with other procedure, using the fiber tape, the graft will not stretch out.
That's a great question. So my understanding of your question is, what about hyperlax individuals? People with Ehlers-Danlos may or may not have that official diagnosis, but you clearly are suspicious. They're hyperlax. They've got 9 out of 9 Baton criteria. I think that's an excellent person to consider an allograft for. I don't know that we have, I can't remember a study that truly quantified whether autograft was not as effective. Maybe there is, but I think an allograft is probably a better choice for those people.
Okay, and in skeletal immature individuals, say there is trochlear dysplasia and there is hyperlaxity, how you approach these patients?
That's a good question. So skeletally immature patients, I think of much like I do with an ACL reconstruction. So if people are in that last year of growth, they're showing the beginning signs of fascial closure. They're not closed, but just the beginning signs of it. Then I will proceed as if they're an adult. And we probably do the same thing with ACL operations. We'll drill our tunnels the usual way and fix our graft the usual way, and that works fine. We may consider with an ACL not using a BTB because the bone crosses the physis. We use a soft tissue graft, or with an MPFL, it's a soft tissue graft and smaller tunnels. And I've not seen any problems whatsoever with growth arrests or anything like that. If they have more than a year of growth left and the physes are wide open, then I think you have to do something different. And by the way, my prior description of that last year of growth applies to trochleoplasty as well. And I did many of these patients that still had slightly open physes with a deepening trochleoplasty, no problem. But more than that, then you really can't do a deepening trochleoplasty because you're going to be involving that anterior aspect of the physis. That's going to typically arrest, and you could get a problem with recurvatum. I haven't had that happen, but I think the potential is too great. So I'm going to try to wait on that person. Same for the tubercle osteotomy, and try to wait until they're skeletally mature. That's a hard situation if these people have profound instability. I think we've all seen those people, and they may be 9, 10, or 11. They have a very pronounced J sign. They're terribly unstable. They can't do any sports at all. They're becoming socially ostracized in their group because they can't do the things their friends are doing. They're tough. It's tough for a teenager in that environment. And you know they need a bony correction, but their growth plates are wide open. And I've seen several people where I'm waiting for the growth to get further along to do it, and they've had another dislocation and sheared a big chunk of cartilage off. And that's the downside to that. So there may be occasions then where the instability is pronounced, where I will do just a soft tissue procedure, understanding that it may fail, but it can be better than shearing off cartilage. That's a hard decision to make. If they have significant patella alta, there is a procedure you can do to shorten the patella tendon. Jack Andrish described it, but you basically feather the tendon in half and you bunch it up with sutures and lay it over the top, and that does work well. So you can correct patella alta with a pure patella tendon shortening procedure, and I have done that successfully in that group. But that's a hard population.
Yes, thank you.
Mm-hmm.
IPS, do you have any questions, or can I mute? Okay.
You are muted, IPS.
Shreyash, you continue, please.
Okay. Now, obviously, in the interest of time, you have covered the important areas, but we have a wide range of audience, right from a young orthopedic surgeon to a very senior and experienced one. So I would just like you to go through a few aspects in terms of patient selection and decision making. Now, we know that over the years, radiography, MRI, and CT, all three have been useful in one way or the other. And there are a number of measurements which have been published, and some are better than others. In your practice, if you see a skeletally immature and a skeletally mature patient with recurrent instability, what is the minimal workup in terms of imaging that you would go for, and what sort of measurements would you be looking at?
Mm-hmm. So I think the measurements that I highlighted in my talk, I'm going to look at those 4 anatomic risk factors on every patient. So I'm going to measure them on every patient. So I'm going to get plain X-rays, standing AP, lateral, sunrise view at 45 degrees of flexion. And then I'm going to get 3-dimensional imaging if they've had patella dislocations on every patient. My go-to is an MRI. So I'll get an MRI almost everybody. Rarely is it a CT scan necessary. That's usually in special circumstances, revisions, etc. But MRI is going to give me information about the cartilage, and it's also going to give me information about the 3D anatomy of the trochlea. So I'm going to see the trochlea. I'm going to measure the TTTG. I'm going to measure the PT-LTR. I'm going to measure the patella height with my CD ratio and my patellotrochlear index. And if on exam they look like they're in valgus, I'm going to get a long-standing hip to ankle X-ray and measure their mechanical axis. So that may be 5% of people I'm getting the long-standing bone. So I'm going to put those numbers together, and I'm going to look at their exam. Do they have lateral tilt, lateral tracking that goes with malalignment? Do they have a jumping J sign? The jumping J sign, remember, right away tells me, got to do something bony here. It's alta or dysplasia or both. And then I'm going to take my measurements. So if my CD ratio is greater than 1.4, I'm going to do something about that. I'm going to correct the patella alta somehow if it's greater than 1.4. If my patella supratrochlear spur is greater than 7 millimeters and it's convex and they have that jumping J sign, I'm going to somehow take care of that dysplasia problem. If I can move the patella down because they have alta and get past the spur by correcting the alta, you can easily measure it for what your final patella position should be, which should be a CD ratio of 1.1. So it's a relatively simple math to end up with a 1.1. And then you say, well, okay, then I'm pretty much past that, that bump. Then maybe you don't need to do anything at all about the dysplasia. And that's probably a safer approach for most surgeons, to just move the tubercle distally and not do the trochlear deepening osteotomy. But if that's not the case, and so I can't get around it by fixing the alta, then I'm going to be considering the deepening trochleoplasty. And especially for those really bizarre shaped trochlea with a big convex bump, the type Ds, those are the ones that probably have to have this procedure. So you've got one group of people, and this is how I started with this operation, that will fail everything else you do. And they failed 3-4 operations done well by good surgeons, and they have that bizarre trochlear anatomy, the type Ds, and they have to have a trochlear deepening osteotomy to fix the problem. There's another group of people that probably benefit from it, but don't necessarily have to have it. And none of us really know the outcome difference, whether that group, if you do it with trochleoplasty or you do maybe just their TTTG is high too, so if you just correct that, which is going to be better in the long run, we really don't know. But we do know that trochlear dysplasia is a contributing factor to patellofemoral arthritis, but we don't really know the 20-year outcomes of my procedure, right? And Gajjar and everybody else. Time will tell. But so that group that may benefit from it, but may not have to have it, I think it depends more on the surgeon's comfort and experience, and you should do an operation that you can do well and safely. It's tough to learn this operation because we don't have a cadaver model that you can go practice on. If you can try to do the procedure with a cadaver with normal anatomy, but it's not the same because it's about having that bump in the front that you drop down. And it's hard to kind of learn how to use these tools. But it's something that it can be done. I mean, I'm not an exceptional surgeon. I just learned this like any of the rest of us and followed the lead of du jour. And it's technically not that difficult, but you have to really respect the cartilage and be very careful and precise about it. So I don't want to suggest that anybody and everybody should just jump into this. It should be people that have a lot of experience with patellofemoral surgery, not to do this on an occasional basis. It should be people who do a lot of this in their practice to consider doing this. And probably one of those types of things that is best done on a referral basis in most countries by a smaller number of people with more experience with it.
Right. Now you mentioned about measurements on MRI. Now we get various slices. So what would be your slice of choice to measure the Catan-Deshaw index and the patella-trochlear ratio? Because that's the most important to determine or rule out patella alta. Yes.
So I'm going to take the sagittal image on the MRI that shows me the longest length of patella articular cartilage. That's my greatest length of patella articular cartilage. And from there, I'm going to measure from that down to the top of the tibial plateau. For those patients who are sitting subluxed off the side, it can be a difficult measurement. It's kind of out of plane there. And that you have to maybe adjust and scroll back and forth. But typically the longest articular length and then measure from there down to the top of the tibia.
On an axial view on MRI, if you see the whole articular cartilage of the trochlea, but you don't see the patella in the groove, would you take it as a sign of patella alta?
Yes, that's a very good point.
Okay, that's great. Now, there are other measurements mentioned. So rather than just the CT scan, there's a measurement on MR where they talk about the trochlear groove PCL distance. Mm-hmm. And it's important for the audience to understand that the two measurements are different. On the CT, it has to be 20 millimeters as the cutoff, whereas on the MRI, it's around 13 to 14 millimeters. Do you measure both to try and make a decision?
I do not. I know some people do and find it helpful, but I do not. I just measure the TTTG, but I also now use the PT-LTR. And I think that number is very useful. And I showed that one example where the PT-LTR was high and important, and the TTTG was not above 20. So I think both need to be taken into account. And some of it becomes kind of common sense. When you look at that axial view and you see the patella tendon over the corner of the lateral trochlear ridge, you understand the vectors at work there, and it kind of makes sense to correct that.
Okay, excellent. Now you talked about the last patient where you showed MPFL with trochleoplasty and also the osteotomy. If you were to do all the three procedures in one patient, what would be your order?
I typically scope the patient first. Then I'm going to do the tubercle osteotomy and fix it. And then harvest my graft, the gracilis, prepare my tunnels in the patella for the MPFL graft, do the trochleoplasty. And then when that's all done, then I'm going to fix my MPFL and use the fluoro. Yeah, that's absolutely the last thing I do. And then after that, and only after that, will I consider a lateral release. And I didn't mention it much, but a lateral release is just at the end to fine tune if it's a little tight. If I've moved the tubercle over or down, I've made the lateral retinaculum even tighter. So it more likely will need a lateral release or a lateral lengthening. But I don't think of that as a way to correct instability. It's more to fine tune or balance the soft tissues. I've gone to a lateral lengthening, a Z lengthening, as opposed to just a release. And that I found is definitely better for patients. You have a lot less swelling and a lot less pain and a lot better quad activation if you do a lengthening, a Z lengthening in a layer, and you let it slide and sew it side to side so you contain any effusion there. There are rare occasions where you have a congenital dislocation, it's fixed lateral, that you have to release at the beginning of the case in order to set it. But in general, it's at the very end. And if I'm doing just patella instability and an isolated MPFL, I'm releasing the lateral side very seldom, 5%, 10% at most.
Okay. Now, obviously, we didn't talk about first-time patella dislocators. Now, you must be aware that there are publications, including a recent one, which says the incidence of cartilage injuries and subsequent degeneration are higher. So the earlier thought was to treat them non-operatively. Obviously, the ones which don't have multiple risk factors. Has that kind of view changed, and should we be a little more aggressive in terms of offering surgical management for first-time dislocators, especially the active group?
Yes, I think perhaps we should, much like shoulder instability. But what it's changed for us is we get an MRI on every first-time dislocator. And if they have bad risk factors, their patella sits subluxed, or they have cartilage damage or loose bodies, we're more likely to encourage early surgery. You can usually, though, let them define themselves and treat them initially non-operatively with physical therapy and bracing, and you'll kind of know. You see them back 3 or 4 weeks, and some of these people just can't progress and they're really struggling, and it's better probably to move ahead with surgery. But we still, I think, just get an MRI in the first-time dislocator and then see what else you're dealing with, and then how they progress.
Okay. Also, in terms of the rehab, so following a first-time dislocation, do you immobilize them for a little while, because there are conflicting views and there's no advantage in literature on immobilizing them? If they are pain-free and comfortable, then you should start mobilizing. And also, what sort of physiotherapy do you advocate to your first-time dislocators?
Yeah, I do send them to therapy. I will try to get them a patella tracking brace, which also helps control the effusion, but I do not immobilize them. I have not seen convincing evidence that you change the natural history by immobilization. So I'll let them move. I'll let them work on their quad. I think probably quad strength is the biggest issue to prevent or have successful non-operative treatment. It's all about quad strength. So that's where I'm going with the therapy. Quad and hip.
Okay, great.
Yeah.
Now, you mentioned that you've spent some time with Dr. David Diduch. Now, he believes that you identify every abnormality and you treat it. Do you follow the same principle?
Well, I think he talks about the a la carte method, and you're kind of figuring out which risk factor you want to address. But I don't correct every risk factor. Many of these people have all of the risk factors to some degree, but I try to decide which ones are most important in affecting this patella. And that's where the art comes in. And I think the combinations are probably most important. And we're starting to see where if you combine risk factors, that the recurrence rate goes up really, really high. I think there was a recent meta-analysis. If you have 3 anatomic risk factors together, your recurrence rate's like 80%. So that's what I wanted to highlight with my talk. The ones that I think bubble up to the top that are most important: trochlear dysplasia, but doesn't mean you have to change the dysplasia. It just means you have to be thinking about how to get around it, and patella alta in that combination. And bad genu valgum, the same way. They're going to continue to have a J sign, and your vectors are terrible. So that's when I'm really thinking about changing it. And a high patella alta in particular, you got to do something about that.
Okay, and one last question. Tibial tubercle osteotomy. A lot of people are moving away from anterior medialization. They're just doing the distalization. What are your thoughts? I
still like the anterior medialization, the basic Fulkerson concept, because I think the vectors that they're improving, and the contact pressures, that's all a favorable thing. And so many of these people have chondral damage. I still like that idea. I just adjust the angle of my cut to whether I want to move it more medial or anterior, and I can easily distalize it too and achieve all those things. I worry more about that transverse cut if I'm just doing distalizations because of the fracture risk. It takes forever for that to heal.
Okay, great.
Yeah.
IPS, anything else?
No, that's okay. You have already answered all the questions because these were sent to you.
You guys had some really good questions.
Question, I think.
Thank you. Thank you very much. Yes.
Hello.
Yes, Ranjit. Yes.
Yeah. One last question.
Okay.
Yeah. When you are combining 3 of the procedures like medial MPFL reconstruction, lateral release, distal osteotomy, have you seen any case of avian of patella. AVN of patella.
I think
Have you come across?
Yeah, he was just saying that when we do these multiple procedures in one patient, is there a risk of AVN of the patella?
Theoretical, never seen it. I don't know if others have, but theoretical, I believe. I don't worry so much about it.
Right. Great. So on behalf of the Indian Arthroscopy Society and personally, I would really thank you very much for taking time off and agreeing to participate. Really, you had a very concise overview on this evolving topic, and we are very grateful for your participation. Thank you very much.
Thank you.
Thank
Thank
you.
you. Very
David.
kind.
Thank you very much. It was indeed
Thank you.
wonderful.
Thank you.
Take care.
My pleasure.
Friends, that was a wonderful webinar of Patellofemoral Instability by Dr. David. Join in tomorrow for a webinar on
Thank you.
7 p.m. on 26th September. The speaker is Professor Yamamoto. He's from Department of Orthopaedic Surgery from Japan. He's going to talk about superior capsular reconstruction. I think SCR is something which is new procedure, and Professor Yamamoto is a pioneer in this surgery. Tune in to IAS YouTube channel at 7 p.m. tomorrow on 26 September to hear the latest on superior capsular reconstruction, the tips and the tricks. Have a nice day. Thank you and take care.
Thank you.
Thank you.
Bye.